I'm going to give a slightly different talk to Claudia. The EMBED-Care programme started in January 2019, so has probably been more affected by COVID. And I used to see all these principal investigators standing up talking about their programme grants, thinking, gosh, that's so slick and it's all working wonderfully. And actually, I've learned that it's much messier than that, especially with COVID. And so I thought what I'd like to talk about today, because we don't have lots of results per se, is more highlighting the work of my team and what they've done over the last year, because they've been amazing. We've got some initial publications coming out as well, which you might be interested in, so I'll highlight those as well. So this is a joint programme between King's College, Cicely Saunders Institute of Palliative Care and the Division of Psychiatry at University College London. So the beginnings were very interesting. So previously, and it's fine to be honest about this, we'd competed with King's and CSI, their palliative care unit, for grants, and we hadn't got them. And over the years, we had become friends. And so despite the politics in the senior levels of the institution, I'd become very friendly with Catherine Evans, who's the co-principal investigator, and our teams had started working together. So we decided that when this grant call came out, we would go in together. And it was a bit of a brave step. Our teams had never met together before. This is a photograph from our first meeting. When we were putting the grant together would have been 2017, and the whiteboard is the absolute mess of ideas we came up with. And it was a really good risk worth taking. And so this is just, the typical Zoom shot of our teams working together during the pandemic. And we were delighted to be funded for the project. So I guess that was the first thing really that I learned, was actually sometimes you just got to take a leap of faith and the trust and work with people that you might have previously competed against, and you can build something really big from that. So the grant's about £5 million, and it's over 5 years, and it's funded by the Economic and Social Research Council and the National Institute for Health Research. I just really want to highlight the team we had. So a key part of the grant call was that we did capacity building for what was called at the time mid-career researchers. So at the time, Catherine Evans and Catherine Sleeman were at King's and were both postdoc, as were Nurea and Kirsten and Nathan, who were postdocs at UCL. So and Claire, who was at King's. And so they were the sort of core application team. And we wanted to make sure that they would really gain from the experience. So that we allocated them all a work stream to lead, so that then they became independent investigators for those particular work streams. We've got a really multidisciplinary team. So we have Richard Harding, who's a social scientist. We have health economics. Janet Anderson, who's a nursing implementation science specialist, large data. We worked with people that we wouldn't have normally worked with on end-of-life dementia care, so people from the National Hospital for Neurology, the Prion Unit, and Jason Warren from the Young Onset Dementia Clinic. And also Jane Ward, who's an expert by experience, who leads our PPI. And then we also recruited Imogen and to fund me and our lovely PhD students. And really the key person was Charlotte Kenton, who's our programme manager. So you can see it's already a really big team of people involved in this grant. So the background as to why this is important is that there are going to be increasing numbers of people dying with dementia as we move forward. And this is a study from Cicely Saunders Institute, and what it shows is the need for palliative care. So these graphs show the need for palliative care. And what they use is the prevalence of pain as a proxy marker of need for palliative care. And you can see that the greatest need for better palliative care and increased palliative care is amongst people with dementia as we go forward into the future. So the dotted line is the estimated prevalence of pain in that population, and the solid line is the estimated need for palliative care. So a massive increase over time. And as you all know, it's the leading cause of death in the UK, and this was really highlighted during COVID. So the overall aims of our programme are to leverage a step change in end-of-life dementia care. We try to be quite ambitious about this and create new networks for care engagement and research. We wanted to develop new knowledge and pilot a new model of care that would empower people with dementia and carers and staff to act upon changing psychosocial and physical needs as people advance in their dementia and as they move between settings. We wanted to deliver a model of integrated palliative dementia care that really enhanced person-centred care and communication and really focused on comfort and quality of life, and physical comfort is very important. We wanted to build capacity in dementia research and deliver very imaginative public engagement, and embed patient public involvement at all points of the project was really important to us. So this is the programme summary, and this is where things start to unravel a bit when we hit COVID, because we had the typical structure where in our first work stream we would do systematic reviews, policy and guideline reviews to inform our own model. We'd do some large data work in work stream 2 to look at transitions and inequalities in care for people towards the end of life with dementia. We wanted to do a cohort study to really pin down what the palliative care needs are for people at all stages of dementia, not just advanced dementia. And then we'd sort of put it all in a pot into a data synthesis work stream. We would co-design our intervention with people with dementia and their carers and staff, and then we would pilot a study, a feasibility study and trial. This is completely messed up, this diagram now, because of COVID, and I'll come on to that. So COVID hit us after about a year, and there were many challenges and many solutions, really. One of the main challenges we had, which was one of the strengths of our team, was that it was a very clinical team. I went back to the Acute Trust full-time. Catherine Evans, who's my co-principal investigator at King's, is a community nurse and works in a community hospital. So obviously she got very much sucked back into clinical work. Catherine Sleeman, who was leading the data work, is a palliative care physician, so she was very busy. And also one of our PhD students, Ali Rose Sisk, is a registered general nurse. And she went back home to Ireland to work in care homes. So the team were amazing in filling those gaps around us. But we managed to find lots of solutions using the remote assessments. We did a lot of public engagement and work over Zoom, and we, like Claudia, managed to really make that work. And the ESRC did give us some extra top-up funding to help mitigate COVID problems. So it was possible to do that. So just thinking about our work streams, an overview of those. The first work stream was actually relatively less affected because this was developing a system-based logic model. And Catherine Evans led this. So this was about doing systematic reviews and meta-reviews, so that's reviews of reviews, to try and understand where the major gaps are in our literature and understanding and the barriers. So it looks quite complicated, but what it does is it highlights what we know, how what we know may change things to then get the improved outcomes that we need. And what we found was some really big gaps. So we found that there's no real structure or framework for ongoing medical review to assess underlying physical health symptoms for people with dementia as they progress. We also found that there's very little understanding of the timing, the duration or the intensity of palliative care need for people with dementia. And we also understood very little about how this care would be delivered and the mechanisms of delivery, because you will all know that it's very messy and some sits in social care, some sits in health. So these are some of the areas that we've focused on as we've moved forward in the grant. And just work stream 2 actually went really well because we were using existing data, and this data is very similar to that George talked about earlier, but we were able to link mental health trust data with acute hospital data with community data, and Catherine Sleeman led this. We wanted to look at the key factors linked to health service use in the last couple of years of life for people with dementia, how those were predicted to change in the future. So this is where you can influence policy and say, look, this is the need now, this is what it might be in the future. And how does community palliative care involvement influence acute hospital use? So we used an observational retrospective study using the South London and Maudsley database system, which brings together lots of health data from people being cared for by the Trust. So this went really well because the data was there, and so Emelle, who's our PhD student, has published on quality indicators for dementia in older people nearing the end of life, and we're going to see whether we can apply those quality indicators to the data. This is deliberately tiny, this graph. She's been great, and she's managed to get a paper accepted in Age and Ageing, which is embargoed but is coming out next week. And all I really want you to appreciate is that all of these lines are people with dementia who have been diagnosed for different amounts of time along the bottom. And the sharp slope up is that however long you've had your dementia, when you reach the last month of life, your hospital admissions shoot up. And this begins to give us really interesting evidence about where we really need to think about focusing palliative care need. So do look out for that. And also really, 20% of those who died, 20% of those who died, they spent 20% of their last 6 months of their life, precious time, in hospitals. Now, some of those might have needed to be there, but others not. So this is really interesting data. We then set up some cohort studies, and this is led by Nurea Kapeli, and we wanted to describe in detail the unmet palliative care need, physical, psychological, social and spiritual, and unmet needs. And this is where sometimes existing data sets don't have the granularity and the level of detail that you need. We wanted to see how carers addressed unmet needs and also explore transitions around carer bereavement. And because we wanted to include previously under-researched groups, we worked with the CJD Support Network and the Rare Dementia Support Group as well, and the Prion Unit. So what we've ended up with is 3 cohorts, and these were really, really badly affected by the pandemic, and I'm not sure we are trying to recover this part of the study. So the general cohort of people with common forms of dementia reaching the end of life has been really severely affected, because we made a decision at the time, which seemed like a good decision at the time, which was that we would recruit people with dementia at the point they were being discharged from an unplanned acute hospital admission, because our previous work had shown that if you have dementia at any stage, if you have an unplanned acute hospital admission, then 50 to 60% of those patients will die within 6 months. So we thought this is a really great way of capturing a potentially end-of-life population, is after they've been in that acute hospital. And previously, we've recruited so successfully from acute hospitals, it's worked really well. Until you have a pandemic and hospital wards are shut down to all visitors, essential work only, and all non-COVID research is stopped. So we needed 253 people in our general cohort. We've only got 53 people with dementia and 33 carers. And we are setting up new sites at the moment to desperately try and catch up with recruitment. And we've also had a PhD student who has been working on carer grief, and she's recently published a systematic review if you're interested in family carers of people living with dementia and how grief affects them. The other study we wanted to do was a study of people with prion diseases. These are rapidly progressive, very malignant dementias where people can die within 4 to 6 weeks. They provide a really interesting paradigm about how you get palliative care in quickly. This has worked better. We only wanted to recruit 20 people as a small pilot study to see if it was possible to work with these patients. The National Prion Unit at UCL uses a hub and spoke model. So they phone people up. They're used to remote working already. They look after people all over the country. So they were able to recruit to the study. So we've got 20 people with prion diseases and 18 carers in that cohort who are under follow-up at the moment. So that's worked really well, and that was a real lesson in terms of how that worked over COVID. And we've also have our PhD student, Ali Rose, who's working on unmet end-of-life care needs in people with frontotemporal dementias, because we really wanted to do some research on young onset dementia and how that worked. And again, she's used a different recruitment mechanism where she's worked with the National Hospital for Neurology and the Rare Dementia Support Group, the RDS, who have a national telephone hotline. And that's made recruitment very straightforward because we've recruited versus the national telephone hotline. So she's actually completed her recruitment. So that's gone well. The fourth work stream is how we put everything together, and this is led by Dr. Kirsten Moore. So another thing that happened over COVID is that Kirsten and our implementation specialist, Janet Anderson, are both Australian. And lots of people who were in the UK from Australia and who had semi-permanently settled in Australia decided to go home and resettle in Australia, because I think the distance, family circumstances changing. So Kirsten's now back in Australia, but is very actively involved in the study. So what Kirsten has done is brought together the information we have so far from the data. We've looked at previous cohort studies to make up for our lack of cohort data. She's also looked at the findings of the meta-synthesis, the systematic review, and other studies and policies. And so what we ended up with was pages and pages of different sources of evidence, so outcome measures from workstream 1, for example, evidence from previous cohort studies, evidence from interventions, other systematic reviews in care homes and other home settings, and then we've thought of every potential unmet palliative care need and filled in pages and pages of tables that kind of synthesise and pull everything together. So the main thing we found from this, because it does seem quite abstract and theoretical, is that the major thing that we don't have are tools where we can assess unmet burden of particular symptoms towards the end of life. So what we've then done is we've identified a tool called the IPOS-DEM, the Integrated Palliative Outcome Scale for Dementia, which really provides a framework for assessing unmet palliative care needs in people with dementia. And this is a pre-existing tool. So it looks at things like pain, shortness of breath, weakness or lack of energy, which most dementia tools don't look at these kind of physical symptoms, but also looks at anxiety, worries, losing interest in things. And one of the really important concepts of palliative care is that of assessment being an intervention in itself. And this is where the underpinnings of the IPOS-DEM come, that if you assess something in detail and properly, it then leads to intervention. And then it also gets people to focus on what the main problems are over the past week. So to give you an idea, so a bit like the goal setting that Claudia's done. And then how they've been affected. And you've got the symptoms there. So this is just an example from some pilot work done previously by Claire Ellis-Smith, one of our team. So the purple line is the initial assessment, and then the inner line is an assessment 1 month later. And what she was able to demonstrate was just by assessing people for unmet needs and not even intervening, you can improve things because it highlights to staff. So this is people who are residing in long-term care. So you can see that the level of unmet needs shrinks just by assessing someone. But obviously we need to be more practical than that. We need to provide frameworks for people to be able to assess people. So we're using the idea of heuristics. Now heuristics are just simple rules of thumb, clinical rules. They are an alternative to using pathways or other guidelines. They synthesise best practice. What they do is they make all that implicit day-to-day knowledge that we hold in our heads about why we do things in clinical settings and care settings, they make them explicit. So a really classic example of a simple heuristic is face, arm, speech, time, the FAST, for alerting the public that someone's having a stroke. And Nathan, one of our leads, had already been doing work on heuristics and how they can be very useful in dementia care. So what we've been doing is then co-designing an intervention where we have the IPOS-DEM tool to holistically assess and identify concerns and needs, but then there's the so what. We've identified these unmet needs, how do we then address them? So that's when the heuristic decision toolkit comes in. That's a simple toolkit to enable people to be supported in their clinical decision making around, well, what if someone's in pain? What if someone's breathless? And there's a manual and training support around that. That's been designed with 3 groups in a co-design process: mild dementia, people with who've cared or carers, and practitioners. And there's been multiple, over 20 co-design groups going backwards and forwards trying to design these heuristics and guidance. And then we're now in the stage where we can implement those and test them in the field. So all of this was done online by Zoom, which worked well, and then we're testing them. What's been really fun, because we've had some money in the programme, is to think about how things are designed and how things look. So very much what Claudia was saying. We want this to look professional. We want it to look really slick. So we've been having some fun working with a designer. This is one way of designing a heuristic, but it's very complicated and not very useful. But actually, that can also be stated like this, where it's much more structured, but probably a little bit too much detail on that side. And this is what we're currently doing this week, is working our way through different design options. And again, that's kind of useful, but a bit busy, but probably better than the first one. So that's been really enjoyable, and we've learned a lot from that. And then we're working with a tech company called Atonics, and the heuristics will be then converted to an electronic platform that's compatible with some of the other electronic care systems that are currently used in social care in the NHS. So obviously we have to think about implementation, and we have 2 PhD students, Stephanie and Juliet, who are working on various aspects of implementation to practice. And Juliet's just published her first paper, which is great, about how e-health can support assessment and decision making for people with dementia towards the end of life. The final work stream, when we eventually get there, is led by Claire, and she is going to be testing the feasibility of the intervention, so a feasibility study and pilot cluster trial, London and Sussex in care homes and home care practice. So that's just a very kind of broad overview. During COVID, we were able to pivot some of our work, so we got some funding to develop a decision aid to support carers of people with dementia and to really help them think about whether they and the person with dementia would want to be transferred to an acute hospital if they became very unwell. So decision aids just state the decision, provide information, summarise options, benefits and harm, and they reduce this idea of decisional conflict when people don't know what to do. So we had rapid evidence reviews, focus groups and co-designs for a decision aid to help people during COVID. This project went really well remotely. This was the final decision aid. It's freely available on the web, and it was implemented into the NHS NICE Dementia Well pathway. So that was very helpful, and we've published some papers from that. And then similarly, Catherine Sleeman and Catherine Evans at King's were able to obtain some funding to look at the care home response to palliative care with a dementia component as well. And so they were able to run this project. So a really big 400 online survey to map palliative care provision, case studies of care homes that have struggled and those have done well to learn from that. So we were able to kind of progress with that. Just to finish off, impact and engagement. This has been really challenging. So we were partnered with a really fantastic organisation called Science Gallery London, which is based on the South Bank. It's led by King's College, and the idea is to draw in local young people into having experiences of the arts and culture around all aspects of science. They've done an amazing thing about black holes a couple of years ago. They did an amazing display and exhibit around anxiety. So they talk to things that young people are interested in. And sadly that was closed during the pandemic. It became a vaccination centre. Staff from there were furloughed. It's run by artists and practitioners and engagement specialists. Some were then made redundant. But happily, again, they've opened up over the last couple of months and we're re-engaging with that work. So we're going to be doing co-creation workshops with young people because dying from dementia affects young people too. They see grandparents, aunts, uncles, and we want to really get their views on that. Eventually, we'll develop some kind of art installation. We've managed to do a YouGov survey, which goes live next week, looking at public attitudes towards dying with dementia, which has been a really interesting process. But you can see there's lots of blanks here that we haven't been able to fill yet. We had a policy summit just before the pandemic with Marie Curie, Carers UK, Alzheimer's Society and all the key charities where we were able to bring them together and think about policy influence, and we're about to plan some parliamentary events. So we're a little bit behind with this. And then just to end, and this is because our PPI group have been amazing. They meet officially once every 4 months, but they've been so engaged throughout our project. Jane has been leading it. They're represented on all our governance groups. We've got people with young onset dementia. We've also been doing more in-depth co-design workshops with the Dementia Engagement and Empowerment Project. I think what I've loved about the PPI is how engaged and supportive they've been of our PhD students. So our PhD students meet with our PPI group once a month. The PPI group have helped them practice doing their questionnaires. They've helped them formulate all their study materials. They have been very supportive in terms of personal circumstances. You know, we forget students are often working in their bedrooms throughout the pandemic. They have been really integral to our work, and it's been a really good experience. So that's just to finish off. It's been a very quick overview, kind of warts and all. We've also had 4 babies as well. Not me personally, but throughout various members of the team, and that's been great because people are now coming back from their maternity leaves and we've supported them through that. So hopefully next time, within the next year or so, we will have some more definite results. But thank you for listening to this very broad overview.